Yes, boys. I have already told you, if you are late, enter in the class and sit down silently. Don't stand there. Yes, boys. Today we will talk about the shoulder joint. The shoulder joint is also named as glenohumeral joint. Glenohumeral joint. Glenohumeral. Glenohumeral joint. Okay. The point is this, that as we have done theoretically, axilla, thoracic region, pectoral region, right? Am I wrong? Theoretically we have done. Alright. Now see the pectoral region. This whole is the pectoral region. This diagram is showing you the different joints present in the pectoral girdle. What are the bones including in the pectoral girdle? Scapula and clavicle. Good. See here. This one is the glenohumeral joint or the shoulder joint. Okay. What is this? Clavicle. This is the humerus. So, look here. The clavicle is articulating with the part of the acromion process of the scapula. The diagram is not showing exactly the part of the acromion process of the scapula. So this joint is called acromioclavicular joint. This is the sternum and this is the clavicle. This is the sternoclavicular joint. And look here, what is this? Thoracic cage. The scapula is also linked with the thoracic cage. Okay, so this is named as scapular thoracic linkage. The purpose of showing this diagram or this picture is to clear you what is the sternoclavicular joint, what is the acromioclavicular joint, and what is the glenohumeral joint. So at present we are having the ideas of different joints of this region. I will talk today about this joint, that is shoulder joint, the acromioclavicular joint and the sternoclavicular joint. Out of these three, the glenohumeral joint is the best example of ball and socket type of joint. All these are ball and socket type of joint, plain synovial joint, saddle type joint, all these are the synovial joints. The synovial joint is further dividing into the ball and socket type, plain synovial joint, saddle type, all these. So these three, that is ball and socket type of joint, and this is the plain synovial joint. Acromioclavicular joint is the plain synovial joint, and sternoclavicular joint is saddle type of synovial joint. Okay, let's talk about the glenohumeral joint. The glenohumeral joint or the shoulder joint. This shoulder joint, which is ball and socket type of synovial joint, and it is freely movable joint. I am using the word freely movable joint. No doubt, hip joint is also ball and socket type of joint, but that is not freely movable joint. Follow this point? The reason is that shoulder joint, which is the ball and socket type of joint, but freely movable joint, this freely movability of the joint is because this joint is least stable. The stability of the joint is weak. Stability of the joint is weak. So this is freely movable joint. Why it is freely movable? The answer is that stability of the joint is least compared to the hip joint. And due to this least stability of the joint, the dislocation of the shoulder joint is very common. Most of the patient will come dropping of the shoulder joint, and the contour of the deltoid muscle is showing the depression. There is a cavity type of space. The person who is coming with the dislocation of the shoulder joint, normally when we see, there is no gap. But the patient who is having the dislocation of the joint, you can see here the very depression. And so keep this thing in your mind. The dislocation of the shoulder joint is very frequent. The doctor corrected the dislocation. Still the patient can come after 1 month or 2 months. The reason is the recurrence of the dislocation is also common. Underline the two things. Dislocation of the shoulder joint is common. लिख लो. Underline का सिर पे करोगे क्या? Why don't you write? Develop the habit. Otherwise, in exam also you will sit. And second thing, the recurrence of the dislocation is also common. All right. Now let's see what are the articular surfaces of the joint. Whenever we talk of any joint, first thing is the type of the joint, stability of the joint, and articular surfaces. In the shoulder joint, the articular surfaces are, one is the head of humerus. The head of humerus is larger than another articular surface. So one articular surface is head of humerus, which is larger. Please close the gate. Head of humerus is larger. The another articular surface is glenoid cavity of the scapula. Glenoid cavity of the scapula. The glenoid cavity of the scapula is short compared to the head of humerus. So these are the two articular surfaces. Both the articular surfaces are covered by hyaline cartilage. Most of the synovial joints, I am using the word, most of the synovial joints are covered by hyaline cartilage. And lining over the hyaline cartilage, there is synovial membrane. So these are the things which are present in the joint. Articular surfaces are two. Shallow glenoid cavity, one. Head of the humerus, which is larger, are second. Both the articular surfaces are covered by hyaline cartilage. And lining over the hyaline cartilage, there is present the synovial membrane. So where is the synovial membrane? On the interior part of the shoulder joint. Under, not out. So if we go from inner to outward, first is the synovial membrane, then the hyaline cartilage, and then the articular surfaces of the bones. All right. After seeing these, let's see the glenoid cavity of the humerus. The glenoid cavity of the scapula is shallow and smaller. Now, what happened? That I told you the head of the humerus is large. So, to hold the head of humerus, the glenoid cavity becomes deepened. So, the deepening of the glenoid cavity of the scapula is done by another structure, and that is the fibrocartilaginous structure. So there is extra thing comes, and that extra thing is the latecomers. Once you enter, why don't you close the gate? So second thing, the glenoid cavity, the depth of the glenoid cavity is increased by the fibrocartilaginous ring, and that this fibrocartilaginous ring is lining over the outer surface of glenoid cavity, and that is called glenoid labrum. So what is the glenoid labrum? Glenoid labrum is increasing the depth of glenoid cavity, and this is fibrocartilaginous ring. After knowing this, the another point comes, the different ligaments of the joints. Before that, see, this is the head of the humerus. You are seeing lying over the head of the humerus the blue color area, fibrous capsule, and this is the glenoid cavity of the scapula, that is also showing the bluish color area. And this is the muscle lining over this. Now I am talking of the different ligaments of the joint. Whenever we talk of any joint, the one ligament which is covering the whole surface, articular surface of the scapula, that is glenoid cavity, and articular surface of the head of humerus. And these are the fibrous sheet, thin fibrous sheet. So thin fibrous sheet which surrounds the glenoid cavity of the scapula, and this is not only surrounding the glenoid cavity of the scapula, but it is extending upward. Listen, completely surrounding the glenoid cavity and also reaching up to the glenoid labrum. Where is the glenoid labrum? That is lining over the outer surface. So glenoid labrum is also covered by this fibrous sheet, and this is attachment on the medial side. On the lateral side, this fibrous sheet is surrounding the head of humerus. I hope all are you knowing the anatomical neck of the humerus. Surrounding the anatomical neck of the humerus, and the tubercle of the head of humerus on the lateral side. On the medial side, this fibrous sheet is descending downward and reaching up to the surgical neck of humerus, which is lying about 1.5 centimeter or 2 centimeter below the anatomical neck. Okay. This fibrous sheet is named as the capsule of the shoulder joint. So instead of initially telling you capsule, now you write down the capsule, the ligaments. First is the capsule of the shoulder joint. And what is this capsule? That is the fibrous sheet. And this thin fibrous sheet surrounding the whole of the glenoid cavity, and above the glenoid cavity the glenoid labrum, and also attached up to the supraglenoid tubercle on the medial side, and lateral side it is attached to the anatomical neck of the humerus on the lateral side, and medial side it is coming down about 2 centimeters. Now generally I have told you, all of you, or if rest, listen again. The question commonly asked, all right, you tell the ligaments attachments, the capsular ligament attached on this spine. The next question of the examiner, why it is below 2 centimeter on the medial side? The answer is for the free movements of the shoulder joint. But still, if the examiner is not clear, you understand yourself. Once you will speak, it is extending downward 2 centimeter on medial side for the reason that free movability of the shoulder joint. I am giving you another example. Look, the shirt on the medial side is not tight, it is downward. If it would be tight, what will be happen during the movement? That it will tear the shirt. Okay. So for the free movement at the shoulder joint, the capsule is descending about 2 centimeter or 2.5 centimeter downward. Or if you can't remember, can say up to the surgical neck of humerus. Clear? Now this whole of the fibrous capsule is lined by synovial membrane. The whole of the fibrous capsule is lined inside by synovial membrane. What is the problem? Why there is a synovial membrane? The answer is synovial membrane lubricates. It secretes the fluid. Synovial membrane secretes the fluid, and that fluid lubricates the joint. So during the movement there is no friction, and we don't recognize. If there is no lubrication, then during the movement we will feel the sound and also the pain. So whole of this fibrous capsule is lined by the synovial membrane. And that synovial membrane is having the few openings. The synovial membrane which covers the fibrous capsule is having the 3 openings. One opening is you feel at the upper end of the bicipital groove. Look here, this is the synovial membrane, and this synovial membrane is showing the 3 openings. One is at, this is the coracoid process, and anteriorly there is the subscapularis muscle. So first opening is at the coracoid process and tendon of the subscapularis muscle. Second, look here, this is the greater tubercle, this is the lesser tubercle. At the apex of the bicipital groove between the 2 tubercles, and this part here, this opening is allowed to the long head of the biceps coming down. If the opening is not there, then how the long head of the biceps will come, which is arising from supraglenoid tubercle and coming down in the bicipital groove. So second opening is at the between the 2 tubercles of the humerus. And not only this give the opening here, also extending downwards into the bicipital groove, and this is called the synovial sheath, okay, which is reaching into the bicipital groove, and this is the long head of the biceps brachial. Alright, so I told you about the 2 openings. Third opening is situated at the inferior angle of the scapula between the infraspinatus muscle. Now the question is, our body is not having any part without function. Keep this thing in your mind. Every part of the body is having the function. So why there are 3 openings? through these openings, the synovial bursa is communicated with the joint. Synovial bursa communicates with the joint, and this is also showing the bursa. So how many the three openings? One is below the subscapularis muscle, that is called subscapularis bursa. Another is the infraspinatus bursa, and third one is acromial bursa. The function of the bursa is for the free movements of the joint. The tendon of the muscles can freely move during the joints without any friction. That is the function of the bursa. So bursa allows the free movements of the tendon without any friction. All right. So I have talked about the first joint, glenohumeral ligament, and second, look here. This whole is the glenohumeral, the capsule of the shoulder joint, and this capsule of the shoulder joint, anteriorly it is thickened at the 3 points. See this diagram. This is the anterior part of the capsule, and the anterior part of the capsule is thickened at the 3 points, 1, 2, and 3. So can we name these as superior, middle, and inferior? These are the parts of second ligament, and the second ligament is glenohumeral ligament. So glenohumeral ligament is the thickening of anterior part of the fibrous capsule. The capsule of the shoulder joint anteriorly thickened at the 3 points, and these 3 points are the superior, middle, and inferior ligament of the glenohumeral ligament. So glenohumeral ligament is consisting of 3 parts: superior, middle, and inferior. The third ligament, look here. What is this? Bicipital groove. The upper end of the bicipital groove is connected with each other by the transverse humeral ligament. So transverse humeral ligament is the ligament which is bounding the upper end of the bicipital groove. So converting this bicipital groove into canal. This one. This is the transverse humeral ligament. The third ligament. This is the coracoid process. Extending from the coracoid process to the greater tubercle of the humerus, there is another ligament that is called the coracohumeral ligament. Coracohumeral ligament, that is extending from coracoid process to the greater tubercle of the humerus. Last, what is this? Glenoid cavity. The upper end of the glenoid cavity is marked by the fibrocartilaginous ring, and that is called glenoid labrum. So this pink color area is the glenoid labrum. That is also the part of the ligament of the shoulder joint. So I have talked about all these ligaments. All these ligaments are complete. Besides these ligaments, there are accessory ligaments. No doubt we are not considering them as the perfect ligament of the shoulder joint. They help during the movements of shoulder joints. So they are named as accessory ligaments. The accessory ligaments include this one. Look here, this is the coracoid process. This is the acromion process. Extending from coracoid process to the acromion process, This is named as coracoacromial ligament. So coracoacromial ligament is the accessory ligament. No doubt it helps during the movement of shoulder joint, that we will talk, but it is come under the head of accessory ligament. One thing I want to tell you here, look this part. This is the coracoid process. This is the acromion process. And betterly you can see this diagram. Look this one. Coracoid process, acromion process, and this is the part of synovial membrane. This is coracoacromial ligament. So these three, the coracoacromial ligament, this one, coracoid process, acromion process, they are forming the coracoacromial arch. Coracoacromial arch. I am talking of accessory ligaments. Accessory ligaments include the coracoacromial ligament, that is this one. Besides the coracoacromial ligament, the second thing includes the coracoid process, acromion process, and coracoacromial ligament. These three are forming the coracoacromial arch, and the function of the coracoacromial arch is prevents the upward displacement of the head of humerus. Head of humerus को ऊपर जाने से रोकता है. That is very important. You can see this diagram that I will come later on. Look here. What is this? Coracoid process, acromion process, and connecting these, third is green color is coracoacromial ligament. So this whole is forming the coracoacromial arch. Coracoacromial arch. After knowing the different ligaments of the shoulder joint, let's see what are the relations, what are the structure related to the shoulder joint, and that we will talk just now. Look this diagram. This is the glenoid cavity. The pink color area is the glenoid labrum. Okay, and this is the part of long head of the biceps. These are the structure anterior to the shoulder joint, the structure lying posterior to the shoulder joint, and structure lying inferior to the shoulder joint and superior to the shoulder joint. So this diagram explains all the relations of the shoulder joint. Now see superiorly what are the structures lying. Just above the shoulder joint, there is the supraspinatus muscle, this one. Above the supraspinatus muscle, this is the subacromial bursa, and this is the coracoacromial ligament, and superficially this is the anterior part of the deltoid. So all these structures are lying superior to the shoulder joint. What is the important thing coming here? The subacromial bursa. See the position of subacromial bursa, just above the supraspinatus muscle and below the acromion process. All right. See the relation anteriorly. Anterior to the shoulder joint, there is another bursa, that is subscapular bursa. Which muscle is lying anterior to the scapula? Subscapularis. Okay, and I told you that bursa in subscapularis part is the subscapularis bursa. So anterior to the shoulder joint is subscapular bursa, and more anterior to it is subscapularis muscle, that is this one. If you go more anterior, that is the pectoralis major muscle. Posterior to this, there is another bursa, infraspinatus bursa, and anterior to the infraspinatus or superior to the, that is infraspinatus muscle, and this is the posterior part of the deltoid muscle. Look the lower down. Previously, in the starting of the class, I told you that dislocation of the shoulder joint is very frequent. And this dislocation of the shoulder joint is more commonly inferior. The reason is superiorly there is prevention, protection by the coracoacromial arch and coracoacromial ligament, and also the long head of the biceps femoris. All these structures, they prevent the dislocation of shoulder above, or they don't permit the upward displacement of the head of humerus. Anteriorly, the relations are protecting it. Posteriorly, the relations are protecting. Now, inferiorly, look, see the diagram first. Inferiorly, the relations is only the part of long head of the tricep, that is this one. Long head of the triceps, and very smaller part teres major, nothing else, no bursa, only the two muscles, long head of the triceps and also the teres major. And above to that, the structure important lying below axillary nerve and also the posterior circumflex humeral artery. So, the displacement of the shoulder joint or dislocation of the shoulder joint inferiorly is very important. And another thing, it is very frequently occurring. And whenever that inferior dislocation occurs, it may compress the axillary nerve or the circumflex artery. After seeing the relation, I again come to the bursa. Now look this diagram. This is supraspinatus muscle. If you remember, the supraspinatus muscle inserted where? Greater tubercle of the humerus. And origin is from supraspinatus fossa. So look, this is supraspinatus muscle. And lying above the supraspinatus muscle, this is the acromion process, and this is subacromial bursa, and this is the part of the deltoid muscle. Better you see this diagram. Supraspinatus muscle. Okay, and lying above the supraspinatus muscle, you can see the coracoacromial ligament. Coracoid process, coracoacromial ligament, acromion process, all these three are named as coracoacromial arch. So coracoacromial arch is starting from superiorly, coracoacromial arch, coracoacromial ligament, and the part is subacromial bursa and supraspinatus muscle, and this is the deltoid muscle. I told you the function of the bursa is they provide the free movements of the tendon of the muscles. So, when the supraspinatus muscle, what is the function of supraspinatus muscle? Anyone? Abduction of the shoulder joint up to 15 degree is carried out by supraspinatus. After 15 degree up to the 90 degree deltoid, and above 120 degree, yes, good, serratus anterior and the other muscle, and the posterior fibers, middle fibers of the deltoid and all that. Okay, so such important thing, the supraspinatus muscle which is lying here, and this is the subacromial bursa. Okay, so keep this diagram in your minds. I am just giving you hint here, then I will come again. Look here, this is the anterior relations and this is inferior relations of the shoulder joint. What are the structures present inferiorly? Axillary nerve and the posterior circumflex humeral artery. Okay. Now let's see. Here, what happened? That in the old days, the old persons are very complicated for the doctors. every time they are making some complaint. Sir, I am feeling pain. I cannot raise my upper limb. What happened? Sir, whenever I raise my upper limb above, I feel that someone is pinching. This is the problem. Maybe because of subacromial bursitis or calcification of the tendon of supraspinatus muscle. Alright. What is this? This subacromial bursitis. What happens in the subacromial bursitis? There is the inflammation of the subacromial bursa. Whenever we use the word itis posteriorly, that means inflammation. So subacromial bursitis, inflammation of subacromial bursa. And another point I told you, the tendon of the supraspinatus muscle is calcified. There is deposition of the calcium at the tendon of supraspinatus muscle. So due to these two, whenever there is a movement, abduction जब भी करेगा तो क्या होगा? Bursa inflamed है. So this bursa will rub between the head of humerus and the acromion process. And whenever there is rubbing, that will be painful. Another thing, the tendon of the supraspinatus muscle is calcified. So same thing will here. When there is calcified supraspinatus tendinitis, that will also create the problem in abduction. Okay, so this is the point which can cause the pain. All right. Before talking of the other points, let's see what is the arterial supply, what is the nerve supply of the joint. The arterial supply of the joint is from the part of the anterior circumflex and posterior circumflex humeral artery. Anterior circumflex and posterior circumflex humeral artery. And second thing, by the suprascapular artery and subscapular arteries. All these arteries, they are coming from the axillary artery. First part, second part, and third part. The nerve supply of the joint is from axillary nerve, main. Besides the axillary nerve, it is also supplied by suprascapular nerve. Suprascapular nerve, and thirdly, from musculocutaneous nerve. So all these three nerves, they are providing the nerve supply to the joint. What's the problem? After seeing this, let's see the various movements at the joint. Very simple. Flexion, extension, medial, rotation, adduction, abduction, circumduction. All these movements are occurring at this joint. But the problem is not solved. The teacher will ask you, okay, tell me the flexion is done by which muscle? So flexion is done by the clavicular part of pectoralis major muscle and anterior fibers of the deltoid. Anterior fibers of the deltoid and clavicular part of pectoralis major muscle. They do the flexion. This is the flexion at the shoulder joint. Extension. Extension at the shoulder joint is done by the posterior fibers of the deltoid and latissimus dorsi muscle. That is this one. That are doing the extension. Do the movements and feel here. In flexion, anterior fibers of the deltoid and clavicular part of pectoralis major. Extension, the posterior fibers of the deltoid, and downward you can feel the latissimus dorsi. Okay, no problem. Then the adduction. This is the adduction. Adduction of the shoulder joint is done by the sternocostal part of the pectoralis major muscle, sternocostal part of the pectoralis major muscle, and also the part of latissimus dorsi. Abduction. The abduction is done by, middle fibers of the deltoid and also the other supraspinatus antis. Medial rotation by subscapularis, lateral rotation by the part of the deltoid and also the infraspinatus muscle and this. So these are the various muscles taking the part in different functions, movements of the joint. Now see the applied. Applied, I told you previously. First is the dislocation of the shoulder joint. The dislocation of the shoulder joint is very common, and the most commonly dislocation occur at the inferior part of the shoulder joint or inferior dislocation of the shoulder joint. And you also add here one more point, that there is recurrence of the dislocation, very common. Recurrence of the dislocation is very common. So after becoming doctor, if you correct the joint dislocation, still the patient comes, don't think that you have done wrong. Rather, you think that this is very common. Okay? Second thing, the frozen shoulder. Again, the problem of old age. Frozen shoulder, F-R-O-Z-E-N, frozen shoulder. What happens in the frozen shoulder? That the fibrous capsule of the shoulder joint shrink, सिकुड़ जाता है. There is shrinkage of the fibrous capsule of the shoulder joint. So when there is a shrinkage, what happens? Also the cavity will narrow or tight, and in this condition the movements will be restricted. Why? Because whenever do the abduction or adduction, there will be pain. So when the person feel pains, naturally he or she will not do the movements. So the movements will be restricted in the frozen shoulder, and this is commonly occur same in the age of 50 to 60 years onwards, but not in all. Take it granted. Most commonly occurs in the age of 50 to 60 years, but I am not telling you that it is common. Okay. Another is which I have told you, that the synovial tendinitis or acromial bursitis that we have talked. After doing all that, we have completed the shoulder joints. But one thing which is very important, and I am taking in last, stability of the shoulder joint. What are the factors which provide stability to the shoulder joint? That I will talk. The stability of the shoulder joint, first is rotator cuff. rotator cuff. Are you listening this word first time? Rotator cuff, including the muscles, supraspinatus, infraspinatus, subscapularis, and teres minor. So first stability is provided by rotator cuff. Second, by coracoacromial ligament. Coracoacromial ligament. Third, long head of biceps femoris. Long head of biceps femoris. Last, glenoid labrum. Let's see, what is the first factor? Rotator cuff. Look this diagram. This is head of humerus. Okay, no problem. The head of humerus is grasped. Pakad mein aati. Head of humerus is grasped by the rotator cuff. The fingers are showing the rotator cuff. Supraspinatus, infraspinatus, teres minor, and this is subscapularis. So, rotator cuff is grasping the head of humerus, and not only grasping the head of humerus, but pulled it medially. So it can be but very nicely held by glenoid cavity of the scapula. All these requirements are done because the glenoid cavity of the scapula is narrow compared to the head of humerus. Head of humerus large है, उसको hold करने के लिए there is rotator cuff. So what the rotator cuff do? That it grasps the head of humerus and pulled it medially in the glenoid cavity. So that is why it is the very important part providing the stability of the joint. If any of the muscle is not working, the rotator cuff will be least perfect. Clear? Now look how it pulled medially. This is supraspinatus muscle, and these are the subscapularis, infraspinatus, teres minor. They pull this head of humerus medially. So that is the way how the rotator cuff helps. Second thing, see the another part. These are the diagrams showing the various movements, and we'll talk later on. The second part, the coracoacromial arch and the ligament. The coracoacromial ligament and arch both are acting as a part, second socket for the shoulder joint, and they prevent the upward displacement of the head of humerus. If the coracoacromial ligament and arch, 5 मिनट जल्दी क्यों आया? ठीक है, बैठ जा तू भी थोड़ी देर. So coracoacromial ligament and coracoacromial arch, they are acting as a second socket which prevents the upward displacement of the head of humerus. सुन लो काम आएगा. The third, the long head of the biceps. The long head of the biceps also prevent the upward displacement of the head of humerus. दोनों खड़े हो जाओ. Get up. Yes. Should I send you letter? Get out. Get out. I am telling you a flight which is important. रुको. बेवकूफ लड़की. Once you don't want to become doctor, then how you will diagnose? if the patient will complain these things? So why don't we be serious? Once I told you I don't want any disturbance. If you are not interested, don't come in the class. At least bother about the attendance. Those students who are coming in the class for the purpose of attendance, please don't come. At least in my class. Don't repeat. Sit down. At this stage, you people should be very sincere to become a good doctor. Rather, wasting the time, your money, everything. So, the third stability provided by the long head of the bicep femoris, that is also prevent the upward displacement of head of humerus. So, it is very clear why the dislocation is not above. But still, some patients are coming with the complaint of the upward dislocation. That is very rare. All right. Now the important point, that when the person coming to the displacement or dislocation of the shoulder joint, so what will be the position? As I told you that normally the contour of the deltoid is very nice and we don't feel any gap. But if there is a dislocation, look here, there is hollow in the shoulder contour, this one. So that will indicate that there is a dislocation of the shoulder joint. So being a good doctor, if you have seen there is the contour is lost, contour of the deltoid is lost, definitely it is the case of dislocation of the shoulder joint. Afterwards, confirm yourself, advice for the skygram or X-ray. But if you know the thing, you need not to go for the X-ray. That is dislocation of the shoulder joint. So that is all about the shoulder joint. These two joints are very simple and I will not go in detail. Look here, this is the acromion process, this one, and this is the clavicle. The joint between the two is the acromioclavicular joint. The type of the joint is plain synovial joint. Plain synovial joint, the movements are along the one axis. The second is the joint between the medial end of the clavicle, and this is the part of the sternum and this. And look here, this joint is called the sternoclavicular joint. The sternoclavicular joint, look here, medial end of the clavicle, and this is the manubrium sterni. And you are seeing here the pink color line, that is articular disc. So whenever there is a disc in the joint, that joint is not a plane. There is no disc here in the plain synovial joint or acromioclavicular joint. So this is the saddle variety of the joint. Sternoclavicular joint is saddle type of synovial joint. The movements are along the two axes. That's all.